Making healthcare affordable to the larger section of the society through applied research and inclusive innovations, we are delighted to have with us today Dr. Syam Vasudevrao, Founder, Director, and President at Forest Health Private Limited. Sir is qualified as a PhD in high-performance computing architectures. We would like to invite Sir to please address the audience.
It was in antivirus space. So since then, it's been a very infectious process. So not satisfied with one startup, then I made one more, and then I have so many of these companies. And more than anything, I would say that it's very important to not just come up with a new technology, but it's also important to see how we get the acceptance in the market. This acceptance comes at various levels. We saw at the HR level, at the people level, the talk which we had just earlier. And in the other end, it is much difficult to get the system to accept it, the government to accept it, the hospitals to accept this. And that is where, I started with universities like Maastricht University Medical Center. I got in that center here in India, and I have today more than 70 plus doctors and life science scientists doing their PhD with us. And we see that how we bring in some of the good practices from Europe and US into India. And also I started this incubation center in one of the engineering colleges. So it's healthcare or sick care. That's a big debate which is going on. Okay? All the healthcare what we see today is not healthcare, it is sick care, I would say. As my friend was telling, only when you fall sick, you go to the hospital. And that is not healthcare. If you need to stay healthy, and if you need to get out of these problems of the non-communicable diseases, we need to see that we get this detected much early. And this is what we see. If you are going to the doctor or the hospital when you are having the symptoms, which is where it is already too late, and the cost of the mortality and morbidity is very, very high. And that is what we are all into, and that is what we see. We are into this loop of the end stage. So thanks to technology, it's trying to pull that a little early. And you have the molecular imaging, molecular therapy, molecular diagnostics, which is basically trying to see a little early stage, okay? At least, in a stage where it is asymptotic, and when there is the first cell mutations, that is the stage when you can catch these problems. And this is showing today, if you see cancer, which was a terminal disease, is no more called terminal, it is a chronic disease now, okay? So that is the improvement we see. There is also certain things which can be detected much more earlier, and that is through protein screening and DNA screening, and these are things which are also catching up in a big way. So the whole idea is here, we are trying to see early diagnostics, personalized medicine, and integrated medicine, and that is what we see as a better and a more efficient healthcare system. So how early should we detect these problems? Is it good, if you detect that even before the baby is born? Well, that's too illegal, I would say, and too expensive. And that is where, we see that the cost of this process of early detection also can be very, very high. In fact, much more than the one what we see today at the end stage. So the most ideal stage would be to do it at the first cell mutation, and that is the space where you see that it is most optimal. And that leads to a whole lot of new possibilities. So if you are talking about a total health care, from preventive to sick care, whatever, you see that healthcare is no more a single episode or a single instance. It's a continuum. It's a continuous process. So we need to reach out to people at an early stage, and that is the reach challenges, and you can see the challenges which I have listed down. I'll not read them all. You need to connect them rightly. Today you have a lot of technologies to connect with people. It's not just a phone call or something, you have a whole lot of things like Facebooks and LinkedIns and all that. How can we use that more effectively? WhatsApp. A lot of doctors, today have adopted WhatsApp. WhatsApp is one of the best thing for them. Earlier they used to use Skype, nowadays WhatsApp. Okay, and also connecting them through intelligence. Today machine learning, artificial intelligence, is in a position to determine at what stage the patient's problem is. When is the right time for them to go to the hospital? Or can they do something with the help of a doctor through a remote connectivity? These sort of things, so that triaging is something, which can also be called as connect, okay? An intelligent connect. And then treating them. Treatment, as you saw now, home care is the next big thing. And treating people at their homes is one of the best things what is possible, both from a patient's perspective and also from the healthcare costs, and also it's an opportunity to create more jobs. This is one of the biggest problems in India today. We need to have more jobs, and this provides a whole lot of new jobs, to people. And then sustaining this. Obviously, this is an important aspect, the insurance and all these expenses. How can we sustain these sort of continuum? Because it is not one-time payment, okay? So this is the continuum, and you see that in all these quadrants, there is a lot of scope for these startups and technology development. I will just run you through a few cases which I have been practicing and what I am doing, and that could trigger more ideas for these students here. So the challenges in healthcare, this I need not reiterate. You can see that aging population, this is not just in India, it's in the Western world. It has been a big thing, very big thing. And then India can help them with technology. India can help them with the right type of resources. And that is where, we see a big opportunity. But then also at home, we are facing this problem of geriatric care. And even here, we need to see how we can learn something from the Western world and see what are the best practices which can be brought in here. Citizen empowerment, or empowering the customers, the personalized healthcare, quality and safety concerns. All these are issues, which are actually the challenges in this space. And I would say that they are all opportunities. Way back in 2011, WHO came out with a wonderful report. It is called the Managing the Mismatch in Healthcare System. And this is a 64-page report. I'm sure a lot of you would have seen this. If not, you can just Google and get it. And this says the 4 A's, these are the 4 A's causing the mismatch. That is affordability, accessibility, availability of resources, or availability of technicians, paramedics, and all that, and appropriateness. This is what is important for technologists like me, because we try to, use technology, very sophisticated stuff to solve a simple problem. So we need to see that what is the most appropriate technology to solve the problem. So these are the 4 A's, which is what is needed to manage this mismatch. So look at a single problem like the non-communicable disease, diabetes. Diabetes by itself is not a big issue, but the problem is, if somebody is not detected for diabetes and they are not obviously managing it with the proper lifestyle, then the morbidity or the comorbidity of diabetes, which is basically loss of there is the neuropathy, nephropathy, retinopathy, and eventually leading to cardiopathy. These are the bigger problems, and you don't know when that is going to happen. Okay? So that is where we see that these numbers, if you see, they are very alarming. And then what is the biggest problem? The problem is that there is a huge loss of productivity due to this single disease called diabetes. And if you see, $236 billion, we lose in India just because of diabetes. And then what is that we are spending is hardly 1%, 2.8 billion or something like that. So 80% of this could have been managed if you could have detected it a little early stage. And that is where, the fuzziness starts. What is this little early? Okay. So for each disease, this time is different and the way you detect is different. And we'll touch upon these two. One is loss of vision and the other one is kidney failure. So this is the new mantra, what most of the companies, most of us are following. And what you see is you have the device, which is basically the heart of the system. More or less, it is the mobile phone, the smartphone. That looks like a solution for everything. But then, of course, there are some attachments and all that. So the device is the first starting point. And then around the device, you have a lot of apps. Okay? There's almost an app for everything today. Okay? And these apps, even though there are so many apps, still you see that there is a need for a lot more to make to fulfill that continuum. And then the mobile-to-mobile communication or the IoT, what we say, that is the other important aspect. So Bluetooth connectivity or Wi-Fi connectivities, and that can make a big difference, can make wonders. And then on top of that, you have these PPP projects, which is what the government is adopting, and that is what, everywhere across the globe, it has been used to scale up healthcare, okay, or any such system. And there you need a whole lot of data analytics and large data management, cloud enabling, and all these sort of infrastructure management and all that. So these are the three layers of our solution. Coming to healthcare, the eye care, we have, most of you here, you would have visited the eye hospital once or twice at least. And if you see, there's a whole lot of things which they do when you get into the eye hospital. There are so many different equipment, and then person is asked to go through this whole cycle, and it takes easily, 2 to 3 hours before you get out. And added to that, there are problems like, they dilate the pupil, and then you'll have to wait. Even after the checkup is over, you'll have to wait till you get back the responses. And that's going to take at least, a 1 full day for you just for an eye checkup. Imagine, this is something, we can all afford maybe, but a person in India, we have more than 60% of the population which is, living on daily wages. For them, this is a very, very big thing, They can't take off for the whole day. And then the entire family is dependent on their wages, okay? So that is one problem. And then also, how do you take all this equipment to the village? That's very difficult. You need to, that's how, the healthcare has been concentrated only in big cities, okay, and in the urban centers. So that's where, we said, okay, is there a way by which technology can play a role? And that's what we did with, of course, these are the costs and all that. That's what we did with this. First, we said, okay, let us take away the process of dilating the pupil, because if you have to dilate the pupil, then, the person has to wait for 3 to 4 hours, and you can't do that, in a rural or in an outside setting, because outside the hospital, if you have to do that, you need a paramedic, a nurse, and they are again, very scarce resource. And this is because there are people who are allergic to these drops. Some of them, don't get back control. Even after 3 hours, then there is a need for medical intervention. That's why, the best is, okay, through technology, you don't need it. You take it out. Okay, of course, it's very easy to put it on PPT, but it has taken me 1.5 years to get to that. But that's one thing. And then once you took it out, you see a big advantage that you can now do all the tests, okay, which were done with so many different equipment in one device. And that's what we call it as Trinetra. And this costs around 1/10 of all these put together. All the tests can be done now within 5 minutes, In just 5 minutes, all the tests are done. And now the person can live. And then the report can get to them, via PDF, mail attachment or something. And for those who want a report, they can just wait for just 15, 20 minutes, they get it. Within half an hour, we close the entire loop. So that was a technology through which we could not only, make it affordable, we could make it available, and also accessible, because this is IoT enabled, and the device is so easy to operate that we can train a technician or a driver to operate this in 6 weeks. And this becomes a job opportunity for them. At the same time, they are in a position to take it out to the field and do this test. And then through the mobile network, they are in a position to connect to the doctor wherever they are. And the doctor from his mobile phone or something, they can report. So this is how the network looks like. So there are several Trinetras in the field. And then they are connected to the cloud. And then the triaging happens depending on the type of problem. If the problem is a glaucoma problem, they connect to the glaucoma specialist. If it is maybe a refractive error, then you don't need to bother the ophthalmologist. Send it to the optometrician or the optical store so that they are in a position to connect to them and provide the right type of service. So, and then the reporting can be done on various form factors, like iPads or Android phones or laptops. So the moment you take away these dependencies and create this sort of a virtual connectivity, you see that there is a whole lot of new opportunities for us to deploy this. And you're in a position to go to the market with different business models. So you see, we created so many different models here. We have mobile clinics, the device put on a mobile, say on an ambulance or on a van, and then they are getting into the field. And one of the things I just forgot to tell you is that this operates on just 6 watt power. 6 watts as against 1.5 to 2 kilowatt power what was needed to operate all those devices in the hospital. So this device works with just a small little solar panel, and you have the mobile network, you have power, then you have connectivity, and then the driver can operate it. So you have everything to get it going in any way, any place. Then we have medical camps. We have deployed them in home screening and vision centers. That is as per the WHO Vision 2020 program. So every 50 to 60 population, you have one such vision center. So it's vision center boiled down to just one device, Trinetra. And then GP's office, this is the model we use in US. We also rolled out this product in the US 2 years ago. We have our office in Palo Alto and doing a lot of sales and services there. Diagnostic labs. Most of the places, if you see the diagnostic labs, they don't have eye testing, okay? But now with diabetes becoming very prevalent, it's also, eye testing is also one of the things, compulsory things for diabetic retina and these labs. So they use this, and optical stores. So this creates a huge business opportunity. And today we have more than 1,800 installations and 25 countries. And we have screened more than 2.5 million people across the globe with this. So then, as I said, it is a very infectious process. You get into this, and then you see, okay, there is something we did, and now we are happy. No, you see that there is another problem. What do you do with children, the school children? You see, we are somehow, very naive. We just say, okay, diabetes, these are the problems. So all the attention is on the working class, because they are the ones who can pay, right? But then there are the ones, who are going to build this nation, the next generation which is coming up. For them also, we need to see. And things like squint, amblyopia, strabismus, these are the most important problems when it comes to the child development. And that is something, we very rarely see that, we have people who come for that. And then to do these tests, we need pediatric ophthalmologists. And in this country, we have just around 200 pediatric ophthalmologists, just 200. And we have more than 200 million kids, in the age range of 3 to 8 years or 3 to 10 years. So imagine, if there is no technology, it's humanly impossible for these 200 ophthalmologists to take care of 200 million kids. And these tests have to be done once every year. So that's where, we said, okay, this is another area where, there is a big problem. No, this is a big challenge. And that's where, we said, okay, let us come up with a device, a simple device like a camera based on a refraction principle. We made this device, and this can detect, and an Anganwadi worker can actually operate this device. And this is, again, IoT enabled. So directly it gets connected to the cloud. And with these images, what this takes, they can detect all these problems of eye at the developmental stage, like amblyopia, strabismus, refractive errors. All these things can be detected. So this is another way of handling the problem at an early stage. And then if they have problem, it is very easy to cure that also. This is done very commonly in the West, where the dominant eye is patched for a week, and then you take out the patch and again do a measurement and see whether it's improved. And if not, maybe do this patching and unpatching session for 5-6 times, and then the baby is most of them are cured. So it's so simple. There is no operation, nothing needed. We are further doing it with an augmented reality. We are creating some games for these kids. Based on the diagnosis, we make the game such a way that the dominant eye muscle is not strained, but the weaker eye muscle is stressed. And with that, we are in a position to cure this. That is the next generation product what we are doing. So because patching, unpatching, kids don't like it, okay? Not even, I am sure adults also don't. Okay. So this is how, again, this is connected to the cloud, and then the doctor, they are in a position to take care of this remotely. And all that they have to do is instruct the health worker what they have to do. Okay? So that's the thing. And only in case, even after several sessions it didn't get cured or something, then they might have to bring them to the hospital and then do maybe, some other surgical intervention. Then if you go further, you see kids, which are prematurely born, they are at a very, very high risk of getting blind. In India, we have 70 lakh babies born every year. Out of these 270 lakh, 40 lakh babies are born premature. And in that, more than 6 to 8% of them are having a very high risk of getting blind because of a single problem called that is ROP, retinopathy of prematurity. And to detect that problem, you need a pediatric ophthalmologist again. And there again, you see that it's dependent on this, on the super specialist. So that is where we said, okay, the other way is to connect them, in the virtual world. But then you need the last mile, that is a device for that. And this is a device which we innovated, but this is out of a sheer need that there is only one device, one company which was making such a device, and that is called Clarity Medical Systems. And the cost of that device, the entry price itself is 1 crore rupees. For the whole of India, we had 16 devices. And we need that if you want to do it through, in a low resource setting. So that's where, we came up with this device. It took us 3-4 years. And today we have this device, and we are in a position to do it at 1/10 the cost. And moreover, it can be managed by a technician in the neonatologist center. Okay, you don't need an expert to do this imaging. So that is the thing. And they do the imaging at the NICUs, and these images are uploaded to the cloud. Instantaneously, it is shared with the doctor wherever they are. From their mobile phone now, they can actually see these images and then decide immediately what has to be done. And this is a real-time problem, I would say, because if a baby is detected for ROP, within the first 6 weeks, it gets blind. Within the first 6 weeks. These babies are born at 32nd week, and then within 6 weeks, they are already blind, and they are blind for the rest of the life. So that's where it becomes important to do this screening in the first 2-3 days after birth, and then this one detected, and then they are in a position to schedule a treatment or follow-up with the doctor, okay, and also the mother and the ASHA worker who bought them, their mobile numbers and all are tagged, so that we can follow it up. The entire process, the workflow is on the cloud, and that is the one which manages the entire thing. And also, this is how we brought in this practice. This is one of the PhD theses of one of the well-known doctors, and he was awarded PhD for this at the Maastricht University. We brought in a practice where you take out the dependency, which is basically an ophthalmologist-led program, to an optometrician-led program. So now, this process is documented, published, well published. It's on the Australian website, CDC, and you can now, any government, anywhere in the world, they can adapt this technique, and you can do that. An optometrician can do the screening. That's what we have done. So this is a big change, and that's where I'm trying to tell you that if you want to innovate something, it is not just making the device or whatever. You see that there's a whole lot of things. You have to think about the whole system, and also you need to go beyond just the technology part, getting into the clinical and also, the research part. So what is that we see is a huge opportunity here. Our body, is a system. It is no more, eye is not just for vision. Brain is not just for the head, okay? So likewise, everything, is all dependent. So if there is any systemic problem in our body, we can do that. We can detect that through any of these parameters. Like eye is one of the best biomarker for various systemic disease. So we have at least 6 to 7 people doing their PhD in this area, and we are in a position to detect Alzheimer's at an early stage by looking at the retina. We are in a position to detect brain strokes at an early stage, Parkinson's disease in early stage. All these, just looking at the eye. And that is what, is the next thing what we are doing, field diagnostics, and we are coming up with very, advanced imaging systems. And with that, we will be in a position to do this early detection. And then treatment at the doorstep, like we heard, dialysis and all that, getting to the homes. Similarly, is there a way by which treatment can also move closer to the patient? If not at home, at least to the CHCs and PHCs to some extent. And that's where we are developing this next generation products, where we are doing lasers. Most of the treatment today, is all minimally invasive and all that, right? Similarly, in an eye, it is all through lasers, and that's why we develop new types of new generation lasers, which are much more environment friendly, and also developing artificial intelligence robotics, which can actually help in image-guided therapy and stuff like that. So the logic, if you apply to kidney care, chronic kidney disease is one of the big problems. In India, we have roughly around 250 million people who are either diabetic or hypertensive. 7 to 10% of them are at a risk of getting chronic kidney disease. And chronic kidney disease progresses very slowly, and it is also very asymptotic. Till the person reaches the end stage, they just don't get to know that they had kidney problem. Had we detected that, in an early stage, stage 1 or 2, CKD stage 1 or 2, even at 4 also, we can help them out with a proper lifestyle, diet, nutrition, and say that, okay, you avoid high potassium stuff, you don't drink tender coconut, these sort of things, and then also more than anything, give them alerts as to saying when you have to go for the next checkup. So that can help them. We can detect such problems 5 to 10 years in advance. That is what we see, in CKD progression. And that's what we did. We have a company now called Renalyx, where we do early detection of this problem. We have techniques to do this, and it's again mobile app based. And then for those who are having problem in stage 1 to 5, they can get onto the care product, which is again another mobile app, which will help them to manage the disease remotely, and with supervision from their nephrologists. The nephrologists have dashboards and all that, through which they can they can reach out to them at the right time. And those unlucky ones who end up at the end stage, we see that they have a dialysis machine, which can work in low resource setting. There are dialysis machines. There are very few companies who make them. They are all in US, Japan, and Germany, but in India we didn't have. But more than anything, it is not the device which was needed, it was the device or a system which is needed, which can work in a low resource setting, which can go to taluka hospitals, which can go to maybe PHCs in a later stage. So that sort of a thing, that's what we have. And today, if you see, we have 1.5 million people, who have reached end stage. That is 15 lakh people, and it's only 60 to 70,000 people who are getting dialysis. Okay, that's the portion what is covered. So, cost-wise, if you see, if to do an early detection, it may cost just 100 rupees, maybe once or twice a year. To do disease management, it costs around 500 rupees. But then if you have to do at the end stage, it costs 2.4 lakhs per annum, and also there is a lot of loss of productivity. Almost they are 50% productive compared to any of us, okay? Because every alternate day they have to go through dialysis. So you see, this is the big impact what you can see. But of course, we have to set in the technology and the mindset, and people have to accept this. And the government has started to work on this. I will come to that in the next stage. So these are the products. This is our dialysis machine. It's a make in India stuff, completely built out of Bangalore, okay? And so we have an early detection product, that is the REACH, and then CARE, which is disease management system, and then the dialysis machine, which we call the STREET, along with a system that is a nephrology information system. So our machine doesn't come just as standalone, it is always connected, and we have an entire suite of products with that, which will help remote monitoring and all sorts of supply chain, pharma module, everything, EMR. It's Aadhaar-enabled EMR, so that, it's easy to reimburse and all that. That's the thing. And then all these components are also built locally, okay? Because we had to overcome the patent issues there. So similarly, we can also, we have a cardio care system. This is to reach out to people during cardiac emergencies. And this is something which is another initiative on the same platform. So finally, to put it all in a perspective, you see that the new system can be that, you have a tertiary care, and then you have the PHCs around, which are all digital PHCs. They are connected through such platform. And then you have mobile workers, these health workers who are going around in the field carrying these sort of small kits with which they can do the tests, and then through the mobile network, it's all getting connected to this system. So there is again, digitally, you are rebuilding the hub and spoke model, which is the best for any healthcare system. So the government is also in a, very progressive now. They are thinking of so many new policies. If you see, these are some of the new policies and guidelines. And there is a guideline for free diagnostic services. I don't know how many of you are aware of it. This gives you an ample number of opportunities to make new devices or new protocols and all that. Please have a look at it. This is free diagnostic policy. And then there is a policy for prevention and screening. So government is promoting this now very actively through NHM. There is a policy for free dialysis. All the while we are talking about affordability. Okay, and now you see that, there are so many states which have rolled out this free dialysis policy. And all those who need dialysis, they can get it free. But of course, there should be availability of resources there, the machines and all that. But nevertheless, once a policy is there, automatically the ecosystem will grow. There is also, a mobile medical units. That's another policy for that. It gives you clear guidelines on how to do it. So in universal health coverage is something India has signed up. How many of you are aware of it? It's called universal health care. So every citizen, has a right for health. That is what it means in this one. So from that, it becomes a big responsibility of the government, big responsibility of the employers to see to it that their employees are kept, their health is managed, and wellness is a big part of it, okay? This is the platform. This is another DG Health platform, which DSP, another company. So the platform is basically, it is Aadhaar-enabled. It is built on Aadhaar-enabled PHR system, personal health record system, and it uses India Stack. And it has an IoT interface to all the devices, diagnostic devices. And you have e-learning and machine learning on that. So it's on a Hadoop open platform where you have machine learning, and e-learning is basically to train the technicians to run CMEs, virtual CMEs. We have 5,000 videos explaining the particular disease, what it means, and how it can be managed. So that's available on this, so anyone who has this problem can actually get that on their mobile. And then there's a whole lot of programs which we have launched on top. That is the applications for cardiology, the diabetic retina screening and treatment, nephrology and all that. So ultimately, Who uses this? Of course, the population and then these sort of health workers. This is the one, this is the kit which they take, go into the villages and do the screening. We are doing that with a lot of NGOs in and around Bangalore, and also in Wardha we are working with Mission Samruddhi, is a big program, and then we work in Banaras, Vanvasi Sevashram, and these sort of people who have a whole lot of health workers, mainly the women health workers who are actually adapting to this, and they are taking this and they are in a position to deliver care at home. Okay. So, yeah, this is the incubation facility what we have to build capacity for startups and with a whole lot of system. So that way we have got a good recognition, and we have been having several awards for this work what we do. We are figured as one of the top 3 innovators in the country, and when the United States, Hillary Clinton, when she was the Secretary of State, when she came to India, she wanted to see that what are the technologies I can take to US. And then we were showcased as one of the ones. And then, you can see that we gave a demo, and also I got her eye tested on my machine. And eventually we ended up also in US. So that way, it's really encouraging. What I mean to say is, whatever you do for India will work for the rest of the world. Okay? People say that, if you know how to drive on Indian roads, you can drive anywhere in the world, right? Exactly the same way I would like to tell you youngsters that if you are in a position to innovate something for India, prove it here, let it do some service, and then, after that, once you mature the technology, you can take it to anywhere in the world. So this is the message I wanted to give you. Thank you. Yeah. So any questions? There's a few minutes for question Q&A. Yeah. Yes. Is it a mic? Or?
Hello. Sir, many congratulations to you. So you have done so great work.
Thank you.
I just wanted to know that what kind of, because you are working with government and starting so many startups, so what kind of challenges you faced, and how was the response from government to help you?
Yes, see, government is really encouraging, I would say, today. The Department of Science and Technology, the Department of Biotechnology, and DHR, these are really, they are first got digitized. All these calls, everything, goes, no more paperwork, everything, is online, and you can track, you can follow up, everything is good. It's only that, there is still challenges of catching up with time. Once we cannot, at least we cannot say that today I will innovate something and do everything with government funds. That is not possible. You will have to go and raise money through investors. There are so many investors just waiting. Everyone wants to find a good project so that they can invest. But then once you take money from these investors, you will see that they start chasing you, and you have to start running. And when you are waiting for the government thing, that comes, you would have already developed half of your product, and then, they give you money, that sort of a thing. But I'm sure they are also realizing that, and it's going to catch up. And there are more and more schemes coming out, not scams, okay, schemes, really good ones, and they are very well managed, and I would say that, it's the right time for somebody to do something, innovate in this space here.
Thank you, sir.
And you saw that there are so many new policies which have been coming out, and government is involving all people from all sectors, and people like us also, we are involved with making these policies or suggesting, recommending some things for the policy. They are hearing. Yeah.
Hello, good morning, sir.
Yeah.
Sir, I just wanted to ask that how we can just pre-calculate the particular outcomes when we are just preaching our information to the remote areas. Because for these startups, if you had just talked about the opportunities for the new ones in the market, so how we can just particularly calculate the pre-outcomes about it?
Yeah, see, that is where, I'm saying that, once you digitize, you see that it becomes evidence-based system. And it's the only way, you know, we can actually make things accountable is if there is proper evidence. And in a more secured way, of course, we use HIPAA and all these standards, even though that's not mandated in India, we use HIPAA standard, all that. You know, you have this evidence-based system through which, you know, evidence-based and GIS, that is geotagging, you are in a position to really show people that what happened, when we did this, who attended this, and we can actually convince anyone, and that is what is needed, that's what even the government is using to do reimbursements and all that. So that way, the clinical outcomes can be very accurately measured in such a situation.
So, but particularly if we are just talking about this information and technology, so how we can just implement in our country over there in the remote areas, basically, in the rural areas where the possibilities is negligible over there to reach?
No, it is, if you see the network, mobile network is almost reached every nook and corner of this country. There are no toilets, there is no water and all that, but the mobile network and things like Pepsi and all that have reached these places, okay. So, we of course, you may not have connectivity in every house, but there is a small little place where there would be a network. That's what we have seen. And there is government also, you know, trying to see every school, every PHC has connectivity. So that way, they are trying to build this network. That's also going on parallelly. Okay, so we didn't find such problems. When we go for screening, what we do is we'll see where there is a network. You know, the CDMA network, or there is this GSM or what you say 3G networks. And based on where it is available, we stop the van there and then start screening. So that's to that level it has almost reached.
So any mantra for the mind capitalization of the recent public to deliver your services and information?
Pardon, what was that?
So any mantra for the mind capitalization of the recent public or to deliver our information, the services? Because if we are just dealing for our delivery, so we need to capture the front-footed mind over there of the person to whom we are talking, or we are conveying our information.
Exactly. See, this is very important. There are very active self-help groups and then, you know, the NGOs who are actually very active in these areas. One of the things what we see is the women. They are the ones, you know, who really can be the drivers for your whole thing. If you want to reach, it is the women there. Okay, we involve them. The NGOs through whom we work, they work with de-addiction programs and all sorts of things. We using these resources, these women in the villages, and they are very powerful, and they are also very much interested in children's education to their health, and I think that is something which we are very much happy, and that's how we could reach. We are in a position to reach out to people. Yeah. Pardon?
Are you an engineer?
Yes, I am an engineer. Yes.
Okay.
But I have a whole lot of doctors with me.
Yes. So how big is your team, and how do you manage your team, and is it spread all over India? Is it focused in the south, in Bangalore? And how is it that you sort of train them and move towards in a single direction?
Yeah, we are not a very big team. We are around 300 people in all my companies put together. But more than anything, as I said, we have the university connects. We work with almost all the good universities, and we are technology providers.
So
we just show the model, and then, you know, we leave it to the NGOs or these big institutions like Mission Samruddhi or somebody to, yeah.
The IT support is by your company?
Yes, yes.
Okay.
IT and technology support.
And technology support.
Some products. Yeah.
So are you open to ideas? Like suppose somebody comes to you with a problem and says we need technology to sort of help us with this.
Certainly. We are very open. And I work with all these, say, IKPs and CCAMP and DBT. And we also have our own incubator in one of the colleges. We are starting 3 more incubators. So we are very open. We want to encourage people to innovate and handhold them, mentor them. Yeah. So thank you.